roles. So at this time, I'd like to introduce Dr. Jennifer Yeo. She's, as mentioned by earlier by Giselle, she's a PGY 3 resident, and she's been doing this for a few years now, and she's passionate about this, and I think I wish all my residents were as passionate about portfolios as Jennifer is. And so Jenny's just going to talk about what this means to her as a resident, and at the end, I'm going to open it up to questions and then show you a sample portfolio. Jenny?
We're still on the air. Yep. Okay. Hi there, my name is Jenny. I thought that the best way to share my passion for the portfolio project would be to give an example, a concrete example of one of my entries in the Collaborator Portfolio. So I guess what's important to note is that this is one of the reflections in one of the roles. So this is the Collaborator Role, which is one of 7. This was the role that was introduced the earliest for us. So we've been doing this role since PGY 1. So I've now done 6 entries like this in the Collaborator Portfolio, and then also some entries in the other 2 that have been introduced so far. So this one comes from my PGY 2 year, and I think if you look for when you're listening to look for the effect that knowing that I need to do a portfolio entry has on me during the experience, because I think one of the points that was made by Dr. Wong was that the having to do the portfolio project helps us to plan our learning activities in residency, and it actually helps us to react in certain ways in given situations. So what I'll do is summarize the first part of this and then read the second half of it. So this is my PGY 2 year, quite a fresh anesthesia resident doing my ICU rotation at St. Paul's, and I'm taking care of a gentleman who has tried to commit suicide by taking a polypharmacy overdose. So he lives on the downtown east side. He's kind of one of these frequent flyers, really well known to all of the services at St. Paul's. And I intubated him when he came in with his overdose, and initiated the renal replacement therapy. And now he's woken up, and extubated him yesterday. Got a psych consult this morning, and the resident came by and said, you know what, he's doing well. He's turned a new leaf. He's going to go home and stay with his sister. I think he's ready to go. Doesn't need to be admitted to psych. Thank you for your consult. So then I go to see him the next morning, and he's got tears streaking down his face, and I address him tenderly, and I say, what's going on? And he says, well, my sister has now said I'm not welcome at her home, and I can't go there. I'm going to go home, and I'm going to take 3 times as much medication as I took last time. And I'm like, oh my goodness, in my little PGY2 anesthesia mind, like, this man is suicidal. He's got a plan, and I'm pretty convinced that he's going to go home and commit suicide. So what do? I write a note in the chart that says that I'm concerned that he's going to go home and commit suicide. And so I page the psych resident who was involved, and she's not available that day, so I page the attending psychiatrist, and she kindly says that she's going to come by and do a reassessment later on this afternoon. So I'll read to you what happened after that. So attempting to finish rounds at the end of the day at around 6 o'clock, I stood with a group of my peers and allied healthcare workers as we discussed another of the newly admitted patients. A woman I did not know briskly approached the group holding my patient's chart and demanded in a loud voice to know which one of us was Dr. Yeo. Surprised by the intensity in her disposition, I stepped out of the circle quickly and engaged her, assuming that there was some sort of emergency. Without introducing herself, the woman barked, "Look! I'm going to tell you a few things about patients with personality disorders because clearly your training until now has not covered that topic." And it's like, taken aback, I felt my face flush. As you guys can see, I flush kind of very, very easily. And my peers tried not to stare, of course, at the spectacle. She continued, "This patient put on a perfect little act for you this morning because he knew that you would naively buy his lines and keep him in, feeding and coddling him indefinitely. He knows the system and he's working it. This note you wrote has tied my hands. If he goes home and takes a bunch of pills again, which he will, and you've documented that he is at high risk of death by suicide, as you have, then if I send him home, then I am liable for his death and I will get sued by his family, not you." If we kept every personality disordered downtown East Side drug user who attempted suicide in the hospital until they were no longer a suicide risk, there would be no room for anybody else. Now, I have never been yelled at in a professional setting before. Initially, I was surprised, embarrassed, and a little confused. When I realized that I must be speaking to the psychiatrist on call, I became a little more oriented. The next feeling I experienced was something like the feeling one gets on their way to a code blue situation. Exhilaration. This was surprising, but the thought in my head, as I was half hearing what the attending psychiatrist was barking at me, was, "This is it. This is a real conflict. Okay, I've practiced dealing with these before. I've talked about all of these principles. Now it's time to employ them." The following may be hard to believe, but during the rant, I had time to apply 2 conflict resolution principles I had learned in seminars and courses and from reading in the past. First, I thought about my body language. My arms were folded across my chest, so I dropped them to a neutral position at my sides. My forehead was knit into a frown, so I relaxed my face and made direct eye contact with the psychiatrist. My stomach was in a knot, and my posture was stooped as if I was bracing for a blow to the abdomen. I straightened, relaxed my shoulders, and took a deep breath. Just as promised by the instructors of conflict resolution courses, these simple actions had a relaxing effect, and I found the flush disappeared from my face. As a result, I was able to employ the second principle, which was reframing the interaction with minimal effort. Instead of focusing on the feeling of being attacked, I could focus on the real issue at hand, which was the optimal care of our patient. Suddenly, instead of adversaries, we were partners, albeit with different perspectives. The next essential step in conflict resolution is denying the impulse to take a defensive stance and instead taking responsibility for one's own contributions to the conflict. As the psychiatrist stormed away, I took a moment to collect my thoughts. Then I followed her to the charting area. I apologized for the difficulty that I had caused her and admitted that I did not have much experience dealing with this type of patient. Next, I asked to hear more about her perspective. Her tone softened significantly, and she spoke with fatigue in her voice about the lack of sufficient facilities and resources to deal with the complex problems of this demographic. I asked how I should have handled the situation in her view. She told me that if she had been in my place, she would have been worried about our patient too. But knowing the system as she does now, she sees that the principle of justice and the need to appropriately triage patients is often the more important factor in deciding who to admit and who to discharge. She told me to try to speak directly to the resident or psychiatrist to develop a bigger picture of the situation before documenting an opinion on a topic that I am not an expert in. She completed her note, and as we walked past my ICU attending physician and my colleagues, she thanked me for my work and apologized for her aggressive approach. She left the department, and I turned to a fellow anesthesia resident with a smile, and he said, "Good job, you'll have to put that one in the portfolio." On reflection, it is clear that some things were done well. I am pleased with the natural way I was able to quickly incorporate principles that I had learned about conflict management. I think a potentially explosive and hurtful situation was diffused as quickly as could be expected. The rapid reconciliation between the psychiatrist and myself facilitated the best possible patient care and gave me the opportunity to develop a bigger picture of the challenges facing my colleagues and the healthcare system at St. Paul's. On the other hand, it is clear that the manner in which the psychiatrist initially approached me was inappropriate. She probably should have asked for a private discussion with me in order to express her feelings or control her emotions as she spoke to me in front of my colleagues, so as not to interfere with the functioning of the team taking care of the patient. In the end, the way the conflict played out, I think, made her realize the error in her approach, and she will hopefully be more collaborative next time. I must admit, however, that the entire conflict could have been easily avoided if I had only called and spoken directly to the psychiatrist or the resident on the phone or in person before writing a note with a weighty opinion concerning a topic that I have only personally dealt with infrequently. These interactions are vitally important. to patient care and smooth team functioning. And I learned two very important lessons. Firstly, it is essential to try to predict the ramifications of my words and actions for my team members. And secondly, apparently a conversation is worth more than 1,000 chart notes. Finally, it is important to strike a balance between assertively protecting your right to be treated respectfully in the workplace and maintaining a humble approach to each new interaction concerning patient care. I believe that the best first steps in this career-long endeavor are to consistently treat others with respect, to strive to model humble collaborative behavior, and to quickly take responsibility for my part in any conflict. This way I can encourage those around me who struggle with conflict prevention or resolution and gently hold them to the same standards over time. So that's one of my entries. And for me, I think knowing that I had to do this kind of a reflective, being trained, I guess, first in collaborator skills, and then knowing that I had to do this kind of a reflection helped me to just be aware that these situations are going to arise, and and I have a toolbox to deal with these situations, and I'm going to make mistakes too. So that's expected. This is par for the course, and then it's kind of what you do with them that matters. And so this was a very valuable experience, and I think every single one of my reflections has kind of had a similar effect for me. And I would say that the biggest barrier that my colleagues talk about is the amount of time that it takes to do these, because it does. This probably took me 2 hours to write out, and when you think, twice a year, 2 hours times 7 different roles, it adds up. I mean, it's not a crazy amount of time, but for somebody who doesn't necessarily see the benefit as much, it's quite a bit. But I would argue that actually it's the fact that it does take time that makes it even more important that we have a formalized, necessary component to our education, because otherwise most of us are going to miss out on this. I do love to journal, but for sure I wouldn't do this much journaling if I didn't have to put a portfolio project together. So for me, it's really validated this bent that I have towards doing this kind of reflective stuff. So I really appreciate all of the effort that you guys have put into, especially to Dr. Wong. It's really good.
So I think you can see why when I hear stories like that, it's very, I don't know, it's hard not to sit back and think, wow, this is really powerful as a tool. So I hear this, I mean, Jenny's exceptional in the way she's done it, and so I think she's almost like a gold standard in terms of how this sort of thing can be used. At this point, I want to open the floor to questions, and then I'll show you a sample portfolio at the end. So any questions from, I guess, UBC first of all?
Yeah, go.
Hi, can you hear us?
Yes.
Yeah, it's Carol Ann Cornea, and I just have a quick question for Jenny to ask her if she said in her brief comments, she said that she really likes to journal and has done it in the past, and I'm curious if she has a background in narrative or what your degree was going into medicine, or is this just a casual interest in journaling, or did you do a lot of it?
Yeah, can you hear me there?
I
think
okay.
It's on.
Yeah, I can hear you.
No, I did a biology degree at Trinity Western University, which is a broad kind of liberal arts education. I don't have any formal training, and I actually didn't even do English at a university level because I got credit for it from my high school IB course. So no, it's just very casual.
Okay, thanks.
Any other questions from UBC? Oh, from Victoria, I guess, Giselle.
Hi, first of all, I wanted to say I really enjoyed the presentation. And I don't know if everybody knows, but the presentations are recorded and will go on the faculty development website so that people who weren't able to be here today can access them. And I wanted to ask that when the people from Diamond Center talk or ask questions in a minute, if they could press on their mics so that everybody can hear. So I had a couple of questions. First one was whether you've ever been asked by other departments or programs to share this or help them with this. And the second was you alluded to the fact, Clinton, about the use of portfolios possibly in continuing professional development for revalidation, and I'm aware that that has happened in England. And I'm wondering what your opinion would be for them, because I mean, I hear Jenny say that it's a lot of work. Do you think practicing doctors would do it? And I guess maybe from Jenny's perspective, does doing this as a resident make you think, more likely to be willing to do that when you're a practicing physician?
So maybe the second question first.
Sure. Yeah, I think it does. It makes me more likely to continue to do this in a formal manner after, because I mean, it's a very strong message that we're getting, that this is important and this is how you do your deep learning. This is how you change on a professional level. So yeah, I think so. It's difficult for me to speak for my colleagues if they're going to do it as a kind of jumping through a hoop and then stop. But I think for a significant portion of us, it will make this kind of a thing more likely to continue.
I'm sorry, I didn't quite catch the first part of the question, Giselle.
Well, the first part of the question was related to how you thought this might play out in CME or CPD, whether people would be willing to do this. And also whether,
for CME, I see. That's a good question.
Would you do it?
I think if I had started it during residency, I probably would continue. You sort of do this informally. I think most of us in here who are sort of my vintage probably did this subconsciously, perhaps. You have a difficult experience, say, in the clinical arena, and you think back upon that, and you think, gee, I didn't feel very good about that. What did I learn from this? And I think a lot of that happens in your first few years of development anyways. And the difference being that you don't write it down, you don't talk to others about it, or you may talk to others about it, but I think largely it's your own internal thoughts about these experiences that leads to a change in behavior. So having it in a portfolio fashion documents this sort of activity, which many of us sort of do subconsciously. I don't know if that answers your question, but I think if if this becomes a regular thing in residency programs, and I think it's easier to implement at the CME level. The barriers that I sense from some residents on doing this is that this is just an exercise. I don't really want to do this, but I'm told I have to do this. I think that might change over time with a shift in culture, but that may take some years.
Okay, thank you. And have you been asked to share this with other departments or programs at UBC? Or?
Well, certainly at the national anesthesia level, when we meet, we share these things with each other to learn from each other what works, what doesn't work so well in our own programs, so that we can sort of learn from that. But beyond anesthesia, this is the first time I've gone outside of to other areas to share this experience.
Thank you.
So questions from here.
So Clinton, can residents kind of create their own halo effect? They come to you each year with these portfolio entries that actually demonstrate what a wonderful job they're doing in their residency. I mean, it would be a natural bias to bring to you good work. And the same way, would a portfolio be discoverable? I've now had a conflict situation at work, and now someone is looking for that record, and they'd like to see what my inner thoughts were and how I did badly, and clearly that provides good evidence that I didn't meet the standard at some point.
So on the first question, halo effect from residents, part of my meeting with them is to provide that outside look at their performance. So if they come to me and say, I did really well on this and I don't really have anything I wouldn't do it any differently. And I'm thinking to myself, well, I'm not sure if I would have done it that way. And I sort of ask a few leading questions as to, well, what about this? Did you think about that? And so that gets them thinking about, perhaps there are other ways that this could have been handled. And I think I sort of open up perhaps their insight a little bit on their performance and suggest at the next meeting that perhaps you could consider implementing some of these things that we've talked about. So I think over time, and I keep notes about very, very general notes about that sort of thing in the residence file. I don't put down any details. So on the question about being discoverable, you know, I'm not sure if residence files are discoverable, but what's in that is sort of my impressions on their performance in the different CanMeds roles and without the details. And that's why I've purposely tried to leave the details out of the residence files. Now, whether the portfolios that belongs to the residents can be discoverable, I don't know. I mean, is your diary at home discoverable? So, question from Brian Warner.
This is more of a comment than a question, and I guess it's, you know, because I am one of those people who's been in practice for 30 years, and I've learned some of the things that Jennifer learned very early on, probably about 15 years into practice, and I can tell you that there are a great number of screaming matches that occurred before I started to figure out that this kind of behavior wasn't productive, and it wasn't really doing me any good, and it really wasn't making me feel any better, and it clearly wasn't to the benefit of the patient. The model under which I learned was the model of mentorship, where you followed the pattern of your older colleagues, and of course the behavior I learned was largely based on the kind of behavior that, although not acceptable at that time, was widely present. And I just am very impressed with how far Jennifer's already come in terms of her understanding of how to collaborate with people, how to interact with people, and how to reflect. See, I'm picking up the jargon right away. How to reflect on her own involvement in the process, and how she herself can make these events less stressful and less potentially damaging in the future. So I know Jennifer's an exceptional resident, and I'm very pleased that we have her in our program. But I do think this is valuable to all our trainees, and I'm very pleased that this is now part of medical education, at least in anesthesiology in Canada.
Sorry.
So, Clinton, I have a couple of interested in your comments, because there seems to me quite a bit of background work, you know, before introducing this assessment tool. I mean, part of it is the fact that the residents have training in the CanMed competencies, so when they're put in a difficult situation, they have some tools to reflect upon that situation and say, I should have done this or I should have done that. Otherwise, you're sort of letting them just go into conflict and then reflect on it without any idea of what to do. So I'm sort of interested in how, what your perspective, as well as the national perspective, of how you build that in to your programs. Is that considered sort of a precursor to this assessment tool?
I don't know if it's a precursor. I think it needs to be done. So, you know, with the accreditation, you have to not only teach the roles, but you have to assess the roles. And I see this more in the assessment end of things. You need to have the teaching part to make this work. And when do you introduce the teaching part? I don't think you need to have the teaching part first. I think they can be done in parallel. So that some of these didactic sessions may not occur before the difficult situation that the resident gets put into. But hopefully when the resident goes to a didactic session about, say, conflict resolution, and had one some months ago, and they reflect upon that experience to think, if I had known that before, maybe I would have done things differently. So perhaps the didactic session imparts a more meaningful thing to them.
Right. And the other thing is, obviously, you're an experienced program director who's dealt with these difficult situations before, and I just wonder how comfortable a new program director would be in counseling residents or discussing their portfolios with them.
So I think on that point, I don't think it necessarily has to be the program director to do this sort of thing. I think you need a champion for portfolios in a program who may or may not be the program director. In this case, I happen to be the person who brought it into our program, and therefore I kind of see myself as that champion. But I don't necessarily think that it has to be the same person, and partly because it does take some time and commitment. So I'd rather see a champion who has that time commitment and to do this, and so it doesn't necessarily have to be. It could be a delegated task to someone.
And in fact, in that way, it sort of removes in some ways, it's like an ombudsman,
Yes.
You remove the conflict of assessing performance to this being really purely a formative assessment tool.
Exactly.
Yeah.
Thanks, Clinton. I was wondering about what kind of guidelines you give the residents, and Jenny, you might be able to answer this well, in terms of what to write. You have 7 CAMES roles that you're doing this around, and it seems clear that for the collaborative role, there must have been some sort of guideline to say, reflect on a situation that you'd been in that involved X, Y, Z. Like what kind of instruction or questions do you pose that help the residents know what to write? And
So I'll just answer briefly, and then maybe Jenny can comment. For the collaborator role, it was felt that conflict situations, because they sort of illustrate or there are situations which illustrate the strongest need for conflict for collaborator roles, I thought those would be very useful. And while conflicts don't always occur, I think if you go through residency, they have to occur at some point. And it's often attached with a lot of strong emotions, and often it's those situations that you remember or you learn the most. And so I purposely, when I designed the Collaborator Portfolio, I purposely said, let's focus on conflict situations and use that as the portfolio model for Collaborator. So that I tell residents to pick a conflict that you're in, either in the clinical or it may not be a clinical situation. It could be a conflict over call schedules or academic day issues or something related, or research issues. So it need not be in the clinical context, but the clinical context seems to be the most common area for conflicts.
But can you give us some examples in some of the other roles of what questions you then pose to the residents to?
Well, the other portfolios I'm less familiar with. I sort of look at them and I sort of I asked them to comment on examples of, say, a communication one. What was the issue about? Maybe there was a miscommunication, and how did that evolve, and what did you learn, and what would you do differently next time? So that would be one example for the communication portfolio, which hasn't been approved yet by our RTC, but that's hopefully tonight's meeting will approve that.
So I think Dr. Wong will show you the Collaborator Portfolio in a minute here, and there's actually very clear wording on that one. On one hand, you have like the scoring system and the boxes that you must check off, and you have to get, I think, 3 points per semester. There's some scoring system to give you a kind of an outline of what you should be doing every 6 months or so. But then underneath, there's a very specific thing that says, give an example of a situation, say who were the people involved, what was the situation. So it's for that one, it's very specific, kind of outline this, and then emphasizing the reflective component. Yeah, see, this is funny, because this is the one we've been focusing on. So the health advocate role is one that's been approved. So one of my things that is in my portfolio for that role is a pamphlet that I made for patients to tell them about the role of epopoietin in preparing for surgery to get their hemoglobin up. So it's health advocacy because it's, for patients. So we're kind of advocating for this group of patients who's coming for surgery. So I made this thing up, but then I also wrote a reflection on the process of making that pamphlet. So these are what the challenges were. This is what I found, this is what I think went well about it. If I had to make this pamphlet again, maybe I would do this or that differently. And then what I did was interviewed some patients who had read the pamphlet and got some feedback from them, and then kind of put that in my reflection. So
Sorry. Leslie, we're not, I think you're putting something up that you're looking at DHCC, is that correct?
No, I haven't been able to put it up. I'm trying to.
Oh, okay.
There's some technical problems.
It's a blank screen right now. I can't seem to connect the laptop. We'll give you a thumbs up if we see it.
I'll answer that question with the manager role. I tell residents that one of the things that new residents, when they finish the program, have the most challenges when they first arrive on call at night, and both David and I were on call at night, so we'll probably we can appreciate this. So you show up at 6 o'clock at night, and you've got a slate full of emergency cases to do. You've got all these elective cases running late. You've got all these nurses on overtime. You've got a lot of surgeons waiting to get their emergency cases done, and they're saying, when can I get my case done? You've got PAR backlogged with ICU patients, and they can't take any more patients. And you're thrown into this challenging situation from a manager role. And I tell residents, you're going to face this when you finish. So we need to help you learn how to manage a limited resource such as OR nurses and PAR nurses and your own time to effectively get through the situation. And while I don't expect residents to be able to do that during the residency, I ask them to learn components of that role during their training. So, I give them responsibilities such as looking after the PAR, and asked that they learn the manager role and reflect upon that experience so that by the end of the residency, hopefully they'll be able to put it together and be able to face that situation more effectively. So that's what I tell residents in the manager role. I don't know if that answers your question. Any other questions? I think we're running close to the 1 o'clock timeline here. So,
can I ask a quick question from UBC? What actual program are you using to present this portfolio? Is it a simple Word document that they're directed to, or are you using some other software?
The portfolio form is a Word document that I send to them electronically. They can print it out, and then they simply write on it. And some of them keep them in a binder with 7 folders. Some keep it electronic and enter everything electronic, and they bring in their laptop and show me what they have on their laptop. So I've seen both ways.
Thank you.
Yeah. Oh, I was going to show you this Word document on screen here. So can you all see that? So this is the instructions are at the very top corner. It's a little hard to read, but just the simple instructions to the residents. Early on, I have revised this form a little bit, Jenny, but early on we had point systems. If you do this, you get so many points. But I've tended to de-emphasize the points and say, just put a tick box behind the different activities. So there's some didactic sessions, some reference articles on this collaborator role. Participation in workshops, and we use simulation in anesthesia, so often there's a conflict in the simulator that they're put into. And then the key part of this is a formal narrative of their experience. I also, I don't know if David Parsons would be happy with this, but I also include the Royal College CanMed's goals and also an excerpt from their fighter on this role, what we're expected to fill out at the end of their training on this role, so that they know what we're supposed to do at the end of their training. So hopefully this gives them a target so that I hopefully will be able to fill out either generally meets or sometimes exceeds or consistently exceeds in those 2 different areas for their fighter.
Clinton, it's kind of interesting. We have always kind of held the fighter back so no one can see it until the last second when you're asked to sign it, right? And at the specialty committee, we've never had any discussion about revealing the fighter document to residents. I can't imagine why we wouldn't, but we've just never talked about it.
Well, it's interesting you say that because I've been told that, maybe this is off the record, but what I have here is a pirated version of the fighter electronic that someone who will remain unnamed across the country has given to me because we're not supposed to have an electronic version of the fighter. It's only a paper version that we're supposed to have. So
I'm sure Dr. Spatafor will give it to everyone.
No. Any other questions?
I have a comment and a question. I'm Luke Chen. I'm joining the clinical hematology staff next month, and I've been thinking about trying to introduce portfolios into the hematology training program for a little while now. So maybe I'll be the first, the other division or department to ask you for advice. But I really enjoyed the presentation today. I thought it highlighted two of the difficulties that I've had with CanMeds over the past few years. One is context. When I was in internal medicine in Ottawa, they used to take us out of the wards one half day every couple of months and go downtown, and we'd have a workshop on some CanMeds role completely out of context, and everyone would completely forget about it as soon as whatever topic it was finished for the day. But Jennifer, your sharing brought out the fact that when we combine this with actual clinical medicine, then it becomes much more powerful. And the second is that I think there's this assumption that most of the non-medical expert roles are being learned in the hidden curriculum, and that's a bad thing. And it's not necessarily a bad thing. I think a lot of things are going on in the hidden curriculum, like people are learning about health advocacy at tumor board or whatever, or by watching their preceptors manage the OR and the PAR. And I think we just need to bring it into the overt curriculum, and I think portfolios allow us to do that. So thank you for demonstrating that can be done. My question, though, is that I think in undergrad medical education, we're very aware that curriculum design is a zero-sum game. You can't add something without taking something away. And I think we're a little bit less careful about that in postgraduate curriculum development. We have the temptation to just keep adding stuff. And when I think about 2 hours for an entry for 7 roles is 14 hours every 6 months. It's a pretty good chunk of time. And I wonder, do you set aside protected time, like, a half day for portfolio development or something like that? Or do you have any proposals for where that time comes from?
That's a very good question. We don't do that in our program. I'm not sure where Jenny finds the time to do it. I'm not sure, it's like saying, are we going to set aside 2 hours during academic day for residents to sit down at a desk and do their portfolios? To me, that's kind of like how I went through grade 5. And I'm not sure if that's the right model in adult education. I think, I don't have a good answer to that, basically. I think I would like to think that, at least in anesthesia training, we're not so demanding that time becomes a major issue. And if anything, there has been criticism that perhaps residents don't spend enough time doing clinical work. I've heard that argument before from some circles. Names will remain unnamed. But I think I see this as a very worthwhile endeavor that is worth the time. Should we as a program provide that time? That's a good question, and we've had that discussion about other areas that we provide in the study time. Should programs provide study time for residents to prepare for exams? And that's certainly a controversial topic in itself as well. So I don't have a good answer to that question.
I could just comment. I think we're quite blessed in our program because we have a full academic day. I think internal medicine, you guys have a half day.
Yeah, I think, like in core internal medicine, they have a half day. For the subspecialties, it's quite variable. Some don't even have a half day. I guess my point is that there's a cost, and if we don't count the cost, somebody else will for us eventually.
Yeah, for sure. I think, in my mind, our academic days often end earlier than a regular clinical day. Mm-hmm. So I think of the extra 2 hours between 3 and 5 in the afternoon of our academic days as kind of like, well, it's a bit of bonus time, and we also have pre and post call days. So there's quite a bit of flex time in our schedule already. So right. I think that we do have research stuff that we have to do as well, and you're right, it adds up over time, and we do have to be sensitive to that. But of course, the clinical time is already being squeezed, so it might be difficult to take away from that.
Right.
I think that's it for questions. I want to thank you all for coming to listen to both Jenny and I for this talk.
Thank you.
Thank you so much, Jenny. That's great. You went very well.
It's always a bit embarrassing to share your journal.
Oh, I know. It's like showing your diary, right? But I think it sends a stronger message.
It does. It's much stronger. In fact, I think you